call the finance meeting to order. Have any public comment? Hearing none, we'll move on to approval of the meeting minutes of May 8th. Is there a motion to approve?
Motion to approve the minutes of the finance meeting May 8th.
Is there a second? Any questions or comments on the minutes? All in favor, say aye. Aye. Motion carries. Next, we have our topic for discussion today, which is Kairos Services from the nursing home. Whoever would like to start. Folks would like to introduce yourselves. Welcome to Carlisle.
Thank you.
Yes.
My name is Jennifer Wagner. I'm president at Kairos Health Systems. This is Chuck Baines. Chuck is our senior director of contracting and network development. Chuck's primarily responsible for the Claremont home and the contracting tied to that. Kairos was set up basically in 1995 by several Lutheran service agencies, and very quickly they were set up because Medicare choice plans came into being, and they did not each want to hire a contractor to do it for them, so they made the company to do it. And very quickly it grew up to 23 shareholders and continues to grow. But since 2008, nobody has had interest in becoming a shareholder. That was when the stock market dropped, and nobody wants to put out that much money. So now, but people still want to become members and use the services. So now, basically, everybody comes in as a service contract member, and they just pay the fee to get the services. We provide services to all post-acute care providers, adult day, home health, hospice, and skilled nursing, primarily for skilled nursing. And we are currently in 6 states. And that's a map of our facilities, Cumberland, Pennsylvania, of course. Our services, we have base services that are covered under the fees, and those include care contracting and support, medical support services, data analytics and support, group purchasing, and then we have additional services that are under consulting, and they are at additional fees that are negotiated for each project that's developed. And I'm going to let Chuck go into those services.
Thank you for your time today and being able to present to you. One of the things I often do talk about, you saw the map of our services area, and two of the biggest regions that we do are Pennsylvania and also Maryland. And the reason why that is those are the 2 biggest markets in the states that we're actually in right now in reference to managed care, managed Medicare. That amounts to over 8,000 beds here in Pennsylvania that we actually oversee the contracting services for, including the facility that you guys are part of. But I want to walk through the services today that you guys have. So the first one is contracting services. The one thing that we do is we look at, first of all, at your market area. What managed care organizations, insurances are in the market area of the home, and who should we be strategically looking at you to contract with. All the contracts we do are individual to the member, so individual to Claremont, that we look at. Sometimes we do get into a national look at contracts, but the rates are regionally focused to the member. Some of that being based on the region people are in, some of it being based also on the quality of care the organization is giving.
Yeah, we don't want a facility that has a high quality to be penalized as a group with a lower quality member. So we always negotiate the rates for the facility based on their performance, not someone else's performance.
Okay, I have a really simple and probably dumb question, because I should know this. Could you tell me what you folks do for us today?
Today we are negotiating your repair contracts. We support the back part of that with your admissions, your billing, to make sure that you get paid for that contract and that you get every dollar you deserve. And then also to address any issues that come up with payment, if there's delays, if there's denied claims, all of those pieces. So basically to make sure you get the money is our primary goal. And there's other support services tied to that, but that's the primary piece.
Okay, so how is managed care going to, how are you going to deal with that for us?
Chuck's going to go into that with
So we're going to that,
the
okay,
status
sorry.
of managed care currently.
Okay, thank you.
Yeah, so I'll kind of walk through this and talk about each of the services, what we're doing for you, and then also get into the managed Medicaid part of the
Okay,
presentation.
thanks.
So we are communicating with your payers, one, to see if the contracts that you presently have need to be renegotiated, as well as negotiating new contracts with the payers on your behalf. At the end of the day, we do send you contracts, and I know that you've received at least 2 contracts already that we've negotiated. And at the end of the day, you can still choose to sign or not to sign those contracts. A lot of the things that we're looking at are terms of the agreement, as well as language in the agreement, but also most definitely the rates of the agreement. As Jen said, we also do some support services. So these help us to make sure you're getting the maximized reimbursement. So we do actually trainings and insurance trainings where we come out to site, and we did one of those at the site to make sure that you guys have the best practices in place. We do give best practice examples of always billing everything on the claim, making sure you have all the right authorizations, making sure you're looking at any carve-outs. We also manage the re-credentialing with the insurer, so every so often they'll ask for re-credentialing information. And since we're doing that for all your payers, we're doing that all at once as opposed to them having to contact the facility every time. So we're managing that as well. And then if there's questions about billing, and we've had multiple questions, I think, about billing some of the providers where you weren't getting payment. So we're able to reach out to the insurer and find out what's going on, why it's not being paid, and hopefully rectify that situation. I think we've ended up with several, especially with the LIFE program that you guys are contracted with, actually payments starting to flow, if I'm not mistaken.
Yes.
We do use a website portal. This is a security area of our site. It is a place where all the contracts are housed. So certain members have access to the contracts of your facility, typically the CFO, CEO of the organization. But we also create a contract summary. These give the details for those clinical teams, those finance teams, so they're doing the right billing to the right places at all times. And as those things change, we update them. It's kind of a one-stop shop because often when we get contracts, they sit in file cabinets somewhere. This kind of becomes that place where you can find out that information quickly and readily because referrals are having to be responded to within a matter of sometimes 15 to 20 minutes when you get a referral from a hospital. So that helps out greatly.
So resident information as part of that?
No, resident information is part of that. It's solely what's on your contract. And on that contract, we'll see carve-outs of what needs to be carved out, how to do that billing, what things need to be authorized. There's some things that don't need to be authorized, some things that do need to be authorized, and how to go about that. We're also kind of, if you're having a problem with authorization, we field telephone calls every day to try to make sure that the representatives at the insurance company are working with you. And then if there's any billing questions that come up, how to try to resolve some of those things.
There's a recent example we have with a facility that converted their EHR system, and they got behind on their billing, so we went to the payers and got them to extend the time of filing extension so that they could get their bills done and get paid.
We're always looking at what are the revenue opportunities for the organization. So what carve-outs can we put in the contract? So some of those are carve-outs that are right up front. Some of those are things that your clinical team sees, and there's a question about this medication coming in. It is not a carve-out in the contract. How can we get that in the contract? How can we do a one-time authorization? So we're looking at things like bariatric equipment, wound care, which are expensive items. Those off-site things like non-medical transport. Some of the contracts will actually pay the facility to do that non-medical transport, as well as the drugs, high-cost drug issues. Those are going to become more and more important as we continue to evolve our medicine system because drugs are getting more expensive for certain diagnoses. The other thing we do is we do some data analytics. What we do is we supply your organization with some quality reports. In your packet there, you'll see a quality report of Claremont as well as the surrounding other facilities. So you can see where you stack up against the facilities in the area. One of that is we do use those quality standards for contracting purposes. So payers know that you're a good fit for their network. We also use that to equip you with any clinical pathways we may have. We have certain clinical pathways that we worked on in the area of joint replacements, pneumonia. We're working on one with sepsis right now, CHF, and heart failure.
So what data of ours specifically is shared with others? Or is it all aggregated?
It's all aggregated, so this is all stuff that's actually
It's all public data.
coming public data
It
through the
just, it
CMS.
comes in a huge database, and so our system breaks it apart for you. And the green is better than state, and the tan is worse than state in that report that you have.
In that data that we also get from CMS on claims mostly, but also quality, we're also looking at people's length of stay. We're looking at people's cost per episode, how much is it costing per episode of a Medicare client. We're also looking at what are the top and bottom diagnoses and top referral sources for the organization. So this helps you assess where you're at with the competitors. This is also all the same information that the insurance companies are looking at. So it gives you an idea of what they're talking about to make sure you can continue to stay in their network. I'm going to briefly talk about Medicare Advantage and how it's different from Medicare, and then I'm also then going to get into the CHC piece of the presentations. So traditional Medicare, or what some people call original Medicare, it consists of A, B, D. You get A for being a retiree, B you pay a supplement for, and D is the prescription drug coverage that was passed into law. Most people choose to pick a Medigap program. Some people call it supplement, other people call it secondary. The technical term from the CMS Center for Medicare and Medicaid is Medigap because it covers the gaps in Medicare. How the plans we contract with are working differently for you is you're not allowed to have a supplement, and A, B, and D are all one plan. They call it a Med C plan or Medicare Advantage plan. So there's more and more people choosing to go with this type of system. I mean, it's actually the insurance we have. And so it's what people want when they retire. How is it growing and why? So 22 million people presently have Medicare Advantage plans as their Medicare. That's supposed to be climbing to 41 million, so it's almost going to double by 2026. Here in Pennsylvania, we're experiencing about 40% Medicare Advantage penetration throughout the state, with some markets at 60%. So if you look at Pittsburgh, they're at 69% as far as the Advantage plan. There are some counties out in the western part of the state that the facilities are actually receiving more Medicare Advantage people than they are Medicare people. How's it? Yeah.
How does Medicare Advantage have anything to do with paying for nursing home care?
So Medicare Advantage pays for skilled care services. So somebody who's in the hospital, traditionally with Medicare, somebody who's in the hospital for 3 days and comes out, they could receive some rehab services either to go home or to return them to a prior level of functioning. Medicare Advantage works much in the same way, is paying for that skilled rehab. The difference with Medicare Advantage is most plans, you're not required to have a 3-day stay. So a Medicare Advantage plan has to act like Medicare, and possibly be better than Medicare. So sometimes there's some dental coverage, some vision coverage, no 3-day stay that appeals for somebody to sign up for a Medicare Advantage plan rather than just sticking with traditional Medicare.
Okay.
Once they get to the point where they're no longer skilled care, then they go into long-term care, which is not covered by Medicare. or Medicare.
Yeah.
Yeah, I think you're permitted, what, about 100 days for Medicare?
Yeah, but most of the insurance, Medicare Advantage plans are giving you up to 14 days for that skilled stay. You can get 100 total for the condition, but they're looking to end it more like 14. And for some hit-me options, it's 10 days.
Okay, I'm sorry to interrupt you that, because I know our big question has to do with the Medicaid managed care, which is, what we're concerned about. So
Yeah.
Go ahead. I'm
Oh,
sorry.
no problem. Feel free to ask questions as we go. just to look at the counties that you're serving. You serve more than this, but Cumberland County and Dauphin County, so about 39% of the population of Cumberland County has a Medicare Advantage plan. 47% of Dauphin County have a Medicare Advantage plan. This was based on this month's data that just came across CMS.
Many employers have now gone to having their retirees pick a Medicare Advantage plan instead of a supplement to Medicare or paying for their full coverage. So we saw that probably in the past 4 years, that change, and that helped drive that number up.
So some of the Part C Medicare Advantage plans you see, they go by the terms of HMO, PPO, Life, SNP, and MSA. What does that mean? So these are traditionally what you see as commercial plans as well. HMO, they're going to have a single network, so they have to stay in that network. The PPO, the preferred plan, they can go in and out of network. Some of those people can come to Claremont out of network, but it may cost them more money if you don't have a contract. And then the SNP plan is a special needs program. These are for people that are institutionally in long-term care. And so sometimes people will have those plans. There's also a Medicare savings plan, which has no network. And then there's the Life program. And the Life program is just a slightly different program. You do have one life care contract. And it is a bundled rate. It's actually called a PACE program on the federal level. And they're an all-inclusive plan that provide care, often through themselves or contract work through, and try to keep people at home. But sometimes they do need nursing home care.
Is the PPO plans the most popular?
Yeah, especially when a company offers both, like an HMO and a PPO, you'll actually see more people in the PPO just because it gives them more flexibility in the market. And there are some PPO plans that actually, one particular that pays the same in network and out of network. We have not been able to get a secure contract with that company, but have given Claremont some tools of how to go about the authorization process for those, so that you can care for those PPO people that don't have a difference in cost, and give them that option. Some of the other plans that we also help to contract with are the commercial insurance, the federal blues, the exchange programs. The next one that we'll talk about is the Medicare Managed Care. As Jen had talked about, there are many retirement companies or companies putting their retirees on these plans. So locally, in our area, we're from Lancaster County. Armstrong's the one that has a retiree plan for their employees, that they put them on a Medicare Advantage plan when they retire from them. Another one would be what people used to call Sperry New Holland or Case New Holland. They have a retiree plan for their individuals as well. And then we also do see some TPAs as well.
We also support for any auto claims or any employment claims as well. Just to make sure they're paid everything they commit to.
So traditionally, the residents that the home serves, they can change yearly in the open enrollment period, but there are some other reasons why they can change. If the plan drops from a 5-star program, if they have a disability, if they can become dual eligible, Medicaid and Medicare, they move out of the area. If they live in an institution, they can always change their plan. But that often happens at the end of the next month. There's also the right return home law for it. And I point this out because there are sometimes you don't have a contract with a company. The resident comes in as a private pay resident, and now they go back out to the hospital, and they need to come in and receive that benefit. There's what they call a right to return home. So if they were living in Claremont and that was their permanent residence, they can return to Claremont. And there would be a negotiated rate that they would work with the individual to be there. Sometimes people will change their plan when they come, but that doesn't happen until the beginning of the next month, so this allows for that to happen. So that's a federal statute. That's the Medicare Advantage piece, which is linked to what the state is doing in Pennsylvania. part of the reason why we're here today is talking about community health choices. So this is the map of community health choices. Community health choices is the plan that the state determined for Medicaid in Pennsylvania. There are 3 regions. We have members in every region. In the southeast, we brought on several members. In the southwest, or the southwest, we brought on several members. Southeast, we brought on more members. Our biggest region, which is the biggest region in the state, is what they call the T region, which includes the I capital, which is the region that we're presently in now. So this is the map of the state in regards to that. There are 3 MCOs, managed care organizations, that the state is working with. In this particular region, the terms that are used are Mara Health, PA Health and Wellness, and UPMC. When I say the terms are used, the reason why I say that is Mara Health uses a different term in the southeast because they also own Keystone. And so they use Keystone in the southeast, which is the blue, and they use Mara Health throughout the rest of the state. They are one company, but they're operating in 2 different regions. We have relationships with all of these companies and have been working on contracts throughout. The reason why the Pennsylvania Department of Human Services decided to bring this to Pennsylvania was, first of all, to operationalize home and community-based services. They're really trying to put people out of the skilled center into the community. And they're trying to do that more and more. I think the state would like to have at least a 50-50 split, if not more people living in the community. They're looking actually to strengthen the coordination of care. With Medicare and Medicaid, sometimes if somebody wasn't in a nursing home, keep in mind, these plans are not just nursing home based, they're throughout the entire dual eligible population, Medicare and Medicaid. They wanted some better coordination of care, and frankly, the state wasn't doing their portion of that. They also wanted quality to follow. Some of these plans do actually have a very good quality standard, and one thing the state is saying is they need to have quality pilots as part of their program. They also want to create some advanced programs for innovation. And so several of these plans, and we've been actually working on contracts in this area, are looking at what they're calling pay for performance or pay for quality plans, which would be above the daily rate that a facility receives if they meet certain quality benchmarks. Because they're really looking to manage that care of that population, regardless of whether they're in the nursing home, the personal care home, the adult day service, or in the community. They're looking to manage that across that system. The big difference between the fee-for-service system that you came from and the system that you're going to be going to is who do you contact for billing and who do you contact for contracting. Rather than dealing with the state and the promise system, you're going to be dealing with an MCF, which is getting money from the government. We want to talk about how it's proposed that you're going to be getting paid. So there's going to be an average of the current fee-for-service arrangement of the last 4 quarters prior to implementation. So implementation is scheduled for 2020. So in the Lehigh Capital region, they're going to be looking at the last 4 quarters, which happens last quarter's information will come out here in October for your rate. One thing that's kind of unique, most facilities are dealing with what they call RUGs, or CMI, case mix index. As a county home, you don't work with case mix index. You work with a rate that the state gives you. We will be looking at both of those rates to help you in your contracting. We did analyze that when we brought Claremont on. And when we brought Claremont on, we looked at what your CMI would be because you still generate those numbers. So the state doesn't use that to pay you. And just to try to determine would that rate be higher or would the rate that the state gives you be higher? It was determined that the rate that the state gives you would be a higher rate. But we'll want to look at that again once we have that data for those 4 quarters to make sure we're best leveraging where you're at as a facility. That rate, in general, will not be adjusted for about 3 years, unless we enter into a renegotiation of that contract. And it will depend on the terms of the contract. That's a plus and a minus, because people's rates might need to go up. Some people's rates might need to go down. If somebody's care mix went down, they would have been getting less care under the state system, but they're actually getting more rate now. And so it's kind of a balance, and we'll be looking at that over time. Because we're not here just to negotiate the contract once, we're here to help manage the contract ongoing. There are also the possibility of an alternative payment arrangement. So there are some funds that are available to facilities that are going to be part of the rate. So see, these are some of the funds that are supplements to the rate that will be negotiated. So the first one talks about assessment. This is typically what they call a non-public facility. People call it the granny tax here in Pennsylvania. And that tax is paid to the state, and they redistribute that among facilities. That's not one that I'm aware that you currently receive. The next one, the disproportionate share of the safety net payment, that is one that you presently receive, and it's one of the ones we have presently been able to get through into your contracts. The Dme exceptions, these are services that are of like, I'll use the example of a wheelchair, very expensive wheelchair that may benefit a resident that you serve. The state has always allowed for a Dme exception, so you put that money, actually it used to be into the cost report, and send it through to make sure that your reimbursement balance is out. Under CHC, they will continue to allow for payment of those items. They'll have to be approved through the managed care organization. But keep in mind, they're going to be managing the entire person's care. So if it makes them more independent, and costs them less dollars in the long run for a resident to possibly get home, they're going to pay for it. The next payment is the assistance, day one assistance. You receive a higher level of day one assistance than others in the state. This is a payment that you presently receive and will be passed through to the facility. And then trachs and vent care, you presently don't do trach and vent care, but that's also another payment that could be received if that was ever decided to do that in your facility.
Any questions on that area before
I just have one. I know it's a rather complicated issue. You said we currently don't benefit from the assessment. Is that what you're saying? Can you explain why or what's involved in that? I know it's a complicated issue.
Yeah. So there was a bed tax instituted in Pennsylvania for non-public facilities and for for-profit facilities. So not for profits and profits, not for county homes. And so the taxes were paid in, and those taxes then are redistributed. And the way it was set up is they originally did it because the federal government had matching funds that went along with it.
Yeah.
So they instituted it, and all those funds then come together and are redistributed based on a formula to those facilities that paid it.
And the idea was to draw down more money from the federal government.
Correct.
Why does Claremont not benefit?
Because you're not paying the bed tax, because it's not.
Man,
Yeah.
we never were assessed it.
No.
Is that because it's a
County.
county-owned home?
Yeah. Yeah.
Okay, so this is a benefit primarily for the for-profit.
And the not-for-profit, actually, probably in Pennsylvania, I mean, there's a disproportionate for-profit, not-for-profit. There's probably more profit facilities in Pennsylvania than not-for-profit, but the disproportionate the share is probably received more so by the nonprofits, because there is some factors calculated in for those organizations that are what we call continuing care retirement communities, because they're caring for people over the life of their time, with the hope that they would actually stay more independent because they could move through the system of care. So there may be more for-profits receiving it, but when you look at putting a for-profit and nonprofit side by side, often a lot of the nonprofits count on those funds because they have to pay money out.
Do you know why the county homes were not included in this?
Well, I don't think that the state wanted to institute a bed tax towards
Yeah, but
local
the
government.
point was that we actually got more money back.
Yeah,
That was the whole point.
yeah,
So we're not benefiting from that at all.
not that. Yeah,
And
that's,
that was the point,
yeah,
I recall. So there would be a bed tax, but actually at the end of the day.
you're supposed to get more money back.
Yeah, you get at least what you put in back, so. Okay, well, I can explore that a little bit further.
Any other questions that you have?
Now, I'm going to just briefly talk about value-based readiness and organizational positioning because payers of all types, from the government payers to Medicare Advantage and Medicaid Advantage, are going to value-based contracting and trying to improve value and manage costs. Definition of the readiness payment model is that healthcare providers are being rewarded for delivering quality care to patients. Providers are seeking to achieve the quadruple aim, which is improving care, improving patient satisfaction, and decreasing costs. The quadruple part of it, the fourth part of it, is also improving provider satisfaction. Physicians and nursing homes and all providers are dissatisfied with the process and the compensation they've been getting and all of those kinds of things. So they're trying to look at that as they put these value-based payments in place. The whole idea, though, is to achieve better health for populations at lower cost while giving patient and provider satisfaction. It links provider payments to improve performance by the healthcare providers. It holds the healthcare providers accountable for both cost and quality of care. And the goal is to reduce inappropriate care. So a big area is like reducing readmissions, managing the length of stay, so you don't go to the 100 days if it's not necessary to go to the 100 days, to manage the care appropriately and manage the costs. And establish preferred provider networks. That's what all the payers are going to be doing. At the end of the 3 years, they are currently contracting all providers for the first 3 years for Medicaid, but they will be minimizing that network and sticking with the best quality providers in every area. The history is basically CMS was the first to go down this path and look at cost and utilization data. 30% of the care was not medically necessary or appropriate according to their study, and the reimbursement system of fee-for-service was driving that.
This is in Pennsylvania now?
This is across the nation,
Okay.
but Pennsylvania also. U.S. costs and healthcare costs are much higher than others internationally with poorer outcomes. Our death rate is worse. Some of the other indicators are worse. So CMS and the government decided that they needed to do something about that to help turn the ship, so to speak. They first applied it to value-based measures to payers. So managed care got an allotment to manage the care and deliver better outcomes. And they are measured on stars, just as our skilled nursing facilities are. And if they do not measure up, they get less money. They are applying penalties to avoidable outcomes. In October of 2018, nursing homes got a 2% penalty for readmissions that were too high. And that's going to go forward as well. There's risk opportunities for hospitals and health systems, bundled payment programs where they're going to get paid a flat amount for a bundled payment for a certain diagnosis like knee replacements, and they have to manage the care and the cost so that they can get those incentives. If they don't, then they have to pay penalties. And then the government also offered meaningful use dollars to hospitals and physicians to increase the capability of their electric health record systems. They did not do that for skilled nursing or home health. And that's been a struggle for this side, for nursing facilities and home health, because they had expected to put that money out to invest in those products, but they were not given any incentives to do that. We provide readiness assessments, but we also help just on the day-to-day with our services to get our members in a place where they can be a better value-based provider. And this just talks about the triple aim again and the focus behind the whole readiness project. Capabilities, what a provider wants to do is align with the healthcare system or payers' goals and objectives. They want to look at their internal operations and processes and do a lean assessment because they want to be as efficient and as effective as possible. Do a competitive market analysis. What can they do to make themselves be the best choice for a provider or for a payer or a health system? Leadership and culture of quality are a big priority. If their leadership is not on board, it will not move forward. IT capabilities are another area where it's important because you need to be able to look at your cost of care per episode of care. So heart failure diagnosis across all your population in your SNF, what is the cost of that care and can you decrease that and still have good outcomes? Clinical care delivery capabilities and medical director involvement. A really good collaboration between the medical director and the skilled nursing team is very important because they can help you drive that quality very effectively. Managing to metrics at point of care, best practices and use of evidence-based protocols. Any variation is going to be costly, so you want to use evidence-based care and manage people to a care protocol to be more effective and have better outcomes. Staffing, skill mix, education, and turnover. These are a big expense to an organization, and we're finding that the skill levels needed in the nursing home are increasing because the acuity of the people coming out of the hospital, they're getting them out faster, they're sicker, and so the nursing staff at the facility has to be better to take care of that sicker patient. Access, do you have the beds? If you don't have beds available, insurance contractor is not going to want to use you. One of the quality incentive contracts that we're seeing from Medicaid in the other areas is that you have to have 90 beds. If you don't have 90 beds, they don't even want to have that quality contract with you, whether that's before you even meet the measures. Your admission process. Hospitals want to get an admission taken care of within usually 2 hours or less. So if your admission process can't handle that and get a decision back to them within that time period, you're going to lose that admission. Care management for high-risk populations. This is an area where it helps manage the care of the patient so that they do not get readmitted, so that they do manage their symptoms and they don't just go back to the emergency department. Coding, billing, and cost to improve financial outcomes. We're finding that coding is going to be so important in the new PDPM process for Medicare, let alone managed care. If you don't code correctly, your claim is going to be bounced right back to you and you won't get paid. So that's going to be very important going forward. And that has not been a big focus in the past for nursing facilities, so that's a big change. And agility, the ability to make changes to remain sustainable, to put in place care protocols, to evaluate what your market needs are, those kinds of things. Sorry, that was a lot. So the areas that we focus on when we're looking to create success are leadership, your market presence, your IT capabilities, your clinical capabilities, access, your admissions department and process, care management, billing and costs, and agility. So that's our deal.
So these rates will be pretty much for 3 years. What do you expect will happen after that?
We aren't sure, but we are already seeing that some of the rates are not going to be for 3 years. They are putting some of the quality programs in place, quality contracts in place ahead of schedule. And we are expecting Their first offers are too low, and we're pushing back already, because the amount of effort to impact the quality, and more importantly, the amount of reporting they want you to do back to them, it's a lot, it's costly. So we want them to pay for that time too, not just pay you to improve the quality. So we're in negotiation on our first couple of those contracts, and we're educating, because the parents don't understand what nursing homes do. They have a little inkling, a couple of them own a couple of nursing homes, but in general, they don't have that grasp. So we use data, and we use proof to get what we want.
These payers active in the other areas that have already rolled this out?
Yes.
Yes.
It's the
Okay.
same for parents.
So they have some experience in it, but they still don't
The
know.
challenge is they've taken on a big project, and they hired a bunch of new people to do it, and those people don't have any understanding. We get calls
Yeah.
so many times in a day from one or the other, or all of them, asking what we think are pretty stupid questions, but it's because they've hired people to manage the volume, and so we're teaching them as we go.
We're also pushing back on the quality standards themselves, and not just the reimbursement, but what makes sense for the nursing home to be able to gather? What information are you already gathering that you don't have to regather?
Yeah, we don't want them to make you go down a different route. If you're already doing falls reporting, then let's keep it the same, and let's keep it the same, with reporting the same way, the same tools that you're using, not something totally different. Readmission should be the same calculation that CMS uses. It should not be a whole new, because you can look at readmissions in 150 different ways. So that's what we push back on too, is keep it consistent, keep it the same to decrease the workload.
And what are the initiatives that actually reduce hospitalization? Because that's what the nursing home wants to do, because we don't want people to go back to the hospital. That's what the payers want to happen. So rather than looking at bow and ladder, we want to look at advanced care planning, or falls, or hospitalizations. We don't want just arbitrary categories. We want things that actually are statistically proven to reduce hospitalization.
We also provide other training besides our billing and admission support training. We provide some clinical training. We have classes coming up on PDPM. And we always analyze what we're providing for training to make sure it is going to be impactful for the facility. Not high level up here, but when you try and put it into operations, you have no clue what to do. We always look at the training to be able to be implemented.
Where do you find people to train? This is on the clinical side, so.
Clinical side, we look all over. We have a clinician that works for us who has, she's been in care management in the payer side, as well as accountable care organizations in hospitals. And so she's my researcher. She looks for people that we need. But then we have them deliver the content, and then we analyze it and see if it's really going to be effective or not.
So let me ask this, first of all, I apologize, but how long have you been working for us as far as?
We are not
How long
quite a
the
year,
contract?
right?
Just the first of the year.
No, first
Well, I thought it wasn't that, hasn't been that long. How many other nursing homes do you work for in the county, if any others?
In the county, yeah, at least 5. In Cumberland County. Our network has about 100 different nursing homes, about 85 in Pennsylvania.
One of the things I think that we're concerned, at least I'm concerned about, I'm going to speak for Vince Gary, but is to make sure, because we believe that our nursing home is special, okay, it's unique. It is a gem, as far as we're concerned. And I've got to be honest with you, I'm a little concerned about this movement into managed care. As you mentioned, they've hired a bunch of people, don't know what they're doing, okay? And that's the beginning of problems. That's the beginning of trouble. Because, you know, we look at our nursing home, we look at the residents there, we consider residents are people, not numbers. Okay? And, you know, I love this. Achieving better health for populations at lower cost. we'll see how
It's
that
hard
works
to do.
out, right? We've been doing more for less for a long time, in Cumberland County and a lot of other places. So if this is all about saving money, the issue is, are we really talking about better health for our seniors, which is a growing segment of our population? And I understand the whole rebalancing thing, we've been talking about this for years, whereas essentially there are probably some people that, you know, could get better service if it was in their home, and maybe they don't need as much as a skilled nursing facility provides. On the other hand, I don't see that there's going to be a decline in the need for skilled nursing home care.
We talk about that all the time, we agree with you.
I agree.
With our fastest segment of the population, growing segment of the population, 85 and older. Okay. So I'm a little leery about this whole thing. What I would like to make sure of is that we're getting the best possible deal that recognizes the benefits that we have in the operation of county nursing home.
That is
I mean,
always
we're not worried about, you know, paying dividends and shareholder benefits here. Our whole point is quality care. So I'm just, you know, just expressing to you my concerns about this whole thing moving forward. How do we know, or what is it that you can tell us that, you know, essentially you're going to get us the best deal?
We are always going to get you the best deal. Because we learn as much as we can about you. We try to build a relationship with your staff so that we know everything we need to know to leverage on your behalf. I don't know if you feel we've done that to date.
I do. I feel that they've been very open and very helpful with what we've needed and very transparent. If you don't mind, Chuck, Chuck was a nursing home administrator. He's worked in the business, so he knows that very well. He was actually one of my teachers at the HAC AIT, the nursing home administration class. Now, they were in place before that happened, so, but I got to know his background too. So, to me, it's wonderful that he comes with that background and knows he's not just some negotiator, he knows what we're after. They got us a contract from UPMC that is paying us for some levels the Medicare rate, and they have special carve-outs. I'm sorry, I can't remember off the top of my head. I think dialysis, wound care, specialty beds, that kind of stuff. And that was one of the contracts that was presented and signed, but they went out and they got that contract. They have another one with veterans to help us bring more veterans in as well. So, and one of the things that he had mentioned was Spirit, I think it was Spirit Trust, where we were months behind. They weren't paying us, and they could say, yeah, we'll get you. Well, the biller called Chuck, and we had payment come in the very next week, and they are all now caught up to date. And could we have gotten it on our own? Probably, but not as quickly as what they were able to get for us.
Where were you with administrator?
I came from a senior living community, Landis Homes Retirement Community. I was actually their director of outcome management, served as interim administrator for their facility twice during my stay with them.
That's in Lancaster.
That's in Lancaster.
That's where I grew up.
Okay.
I see you guys are from Lancaster.
Yeah. I was there.
I'm good with that.
I was there 17 years. And one of the reasons I came to Kairos is because I actually had the experience on the facility side of working with Kairos. And it was known that I only came to them with the hard questions because I would use their tools to figure out how do we get the best reimbursement. And so like I would call up at the office and say, what do I do with someone who doesn't have Medicare and isn't signed up for Medicare and just got kicked off their retirement plan? And they would be like, we're not sure, but we're going to find out. And they would get the information back. I remember one of our other contractors, Kelly Palmer, we had that conversation. She's like, why do you always come up with the difficult questions? Because you trained me well. And so now I work for Kairos. But I hear what you're saying. Your residents are unique and you care about them. And I know what it's like to sit in a facility and know that we're caring for people. But we also want to make sure that the reimbursement, the dollars, the quality that you guys give follows. And I know, this fluctuates up and down, but you guys are a good provider. And we want to make sure that you have the tools to continue to do that.
Ray, do you have anything you want to comment on or add?
Well, I mean, from my experience, companies such as this are incredibly helpful. I've had situations where they said, oh, well, let the administrator negotiate the contracts. No training, no nothing, and we're trying to figure it out and do the best we can. It just made a lot of sense because they can go into areas that I could never even come near. They have connections that I never would know and can get us contracts that we would fight for on our own and would never even touch or even get their attention, much less, be able to get something and they can get it for you like that. They're fantastic. Not only that, this is all they do. There are organizations that say, oh, well, I'll do that for you, but they're also a law firm or something else. You gotta keep that in mind. This is it. This is what they're all about, so that's the focus.
Jennifer, I was a little concerned about your comment though about the hospitals. They want to make sure that we have, you said 90 beds available?
That's an insurance company.
Or an insurance
Not available, but 90 beds occupancy. They don't want somebody that's 50 beds.
I don't know that we have 90 beds available.
Oh,
Yeah, they don't want to bother with a facility that has a smaller number of beds.
Now, I understand. I was thinking, well, we're going to have to build another wing.
Yeah, they just want to make sure they're brokering with the larger providers so that
And the
they're not
other
wasting
piece,
their time.
the other piece we're going to see is these three payers want to move into Medicare. The ones that are in Medicaid,
Mhm.
they want to grow their Medicare population because they know that's supposed to double by 2026.
Mhm.
So they're already contacting us to figure out how are they going to move into getting those dual eligibles to pick them for both Medicare and Medicaid. And so they're going to be looking for incentives to the facilities to help them do that. Kind of like the Optum program, the ISNP program is a long-term insurance, not long-term insurance, a long-term care coverage. And so they're going to try and pull those people from Optum and convert them to them for Medicare and Medicaid dual eligible. So they're going to look to grow their business as well. And they're going to look to grow it through their provider network.
One of the things you said caught my ear, and I want to make sure I'm characterizing this correctly. You said about how they've hired so many people that people don't have thorough knowledge is what they need to. And that's somewhat understandable considering this is from the ground up kind of effort. It sounds to me, if I'm hearing this correctly, that the fact that they have to rely on you actually can work to our benefit because we're having a substantial amount of influence on the final design of what's coming out, so that might be
Yeah, just their
blessing in disguise.
their credentialing process. They had no idea where they wanted to start with that, and we offered suggestions, and then they kind of added extra stuff that was totally crazy, and we said, no, that there's no reason to have that. Medicaid doesn't require it, the state doesn't require it, Medicare doesn't. So we showed them regulatory wise why it wasn't necessary, so then they back off on it. But yeah.
I mean, one of our concerns, as this has been in front of us for a while now, is that this was going to be a computational process. And it sounds to me as if it's going to be a lot more give and take than what we were.
It will for us,
Yeah.
but I'm not so sure if you're on your own,
Yeah.
if it wouldn't be, because you don't have leverage. They looked at, because Kairos won't bring on a facility that's under a 3-star overall. Now, you might drop down from time to time, but when we bring you on, we want you to be a 3-star because we leverage the quality of the group. And the payers know that. They know our places are the places where people want to go. And so that does help a lot.
Steph, have any questions?
No, I had a question on the bed, but that was answered. It was like, oh my gosh.
This gets we're planning for it now, but it gets implemented 2020, is that?
2020.
January 1st, 2020.
And then
And
it's
we'll
ongoing.
be on top of it when you get, to make sure you get paid right away.
Mhm.
All of that, because there was a glitch this year with
Yes.
Southeast, and they weren't getting paid, and so we got on that right away, and that's been resolved.
Yeah, I can see the insurance companies, like if you don't code it right,
Mhm.
I can see them saying, oh, I'm trying, too bad, you're not getting paid.
Well,
Because
they're all
they just keep the money, right?
Yeah.
So, I mean,
Definitely.
you know, it might have been a simple mistake.
Yeah, one of the
Yeah,
things, one of the things we really push is that claims are itemized by everything you're delivering, because payers track those dollars to determine your payment. And for years, nursing homes would just put a flat rate and nothing else. And so when we would go to the table, they'd say, well, you haven't proven that you need anything more, so we keep preaching. Please itemize everything. You may not get paid for it, but put it on the claim so we know it's out there and it's documented.
That way we can go back to them and say, hey, this facility's really taking a beating on high-cost drug. And get that carved out of the next contract hopefully. Because they still, if you providing good quality, and people aren't being re-hospitalized, they want them in your facility because every hospitalization that hits costs them a ton of money compared to keeping them in place.
And we already itemize the bills.
Yes,
Yes.
yes, we're pleased with that.
See, I will say one of the things the board's talked about for quite a while is the fact that we need to not sit back and let things just happen to us, and there's a recognition that having the right expertise would be worth the expense to the county. So let me ask this, how many organizations are doing it on their own, or?
There's a lot, there's a lot who use us, but they don't use all the resources that we give them, and therefore they're, I did an evaluation 3 years ago of the payment that, our members were getting to the contract. 25% of the payments were less than contract. And some of them substantially less than contract. And we could have addressed that. I tell all of our members, if you haven't been paid in 45 days, you should call us. And definitely in 90 days, we better be in the picture, because there's no reason that you should not call us.
There's a lot at stake for facilities with this transition, so that needs to be an expertise, both in-house, but recognizing what we need as well outside. So.
My background is not nursing home. I did work in a nursing home for a while. We did respiratory therapy in nursing homes. And so I always tell people, why don't you do trachs? You should be doing trachs. But, and then I did hospital, and then I did home care for a long time, and disease management programs. So improving quality was a big focus of mine, and saving money. And it was amazing that what we could do with ER visits and readmissions just by managing the disease appropriately. But I got into billing somehow. Somebody told me I should do billing, and got into that, and started doing contracting, and then came to Kairos, and very quickly realized that nursing homes were way behind where I had been, and I thought I was not that far ahead. So my goal has always been to get everybody every dollar they can and do it effectively.
Okay. Well, thank you folks for coming in.
Thank you.
Appreciate the information.
We appreciate your time.